Ilkka Kunnamo, adjunct professor of general practice at the University of Helsinki, Finland, and I'm co-chairing this session together with Anouk Baghus from the Netherlands. I welcome you all to this last plenary session of the conference focusing on e-health and professional health with Ulrik Kirk from Denmark and Lieve Peremans from Belgium as speakers. The topic of these sessions are most interesting and timely because the pandemic has resulted in the mandatory upsurge of e-health and a lot of research opportunities on implementation. The pandemic has also created a significant threat to professional health and well-being and a need to mitigate those threats. Please ask questions from the speakers. You can start submitting your questions immediately in the Q&A panel on the right side of your screen. I will pick and read them loud after the presentations and try to fit as many questions as time allows. My co-chair Anouk will now present the first speaker.
Yes, thank you, Ilkka. And thank you for being here with us, Ulrik and Lieve. First, I will introduce Ulrik from Denmark. He is an expert in digital health and improving research and innovation in the European primary healthcare setting. He has been working as a manager for the European Society of Quality and Safety in Family Practice for years. He prepared a very interesting talk about e-health for us. So Ulrik, the floor is yours.
Thank you and good morning, everyone. You can hear me okay, and I hope you can see my slides. So all should be good. So yesterday was actually my birthday, and I couldn't have thought of anything better than being able to talk about one of my favorite topics today, namely e-health. So in the next few minutes, I'll go through that. And just for the formalities here to begin with, I have nothing to declare. So my question for this talk would be, how can we strengthen primary care by introducing digital health solutions? And what have we learned from the pandemic so far? I had an interesting talk with colleagues from Ireland a week ago, and they trusted me that they had quite interesting experience jumping 10 years in a single year. So we can learn a lot from general practice, and that's one of my take-home messages of today's talk, that we should learn a lot from general practice in family medicine because much innovation has happened in e-health. But we also need to build up new robust repositories. We need to bridge research with practice. We need to also apply new methodologies to be more practice-based in our research. And we can use this to guide policymaking. So why don't we insist on guiding policymakers even more with our research? Well, that's my three take-home messages from today's talk. I'm Ulrik. I'm actually from the humanities. I've been doing a lot of media studies. So that's my main interest in this. How may technology contribute to improve society? How when you interact with technology between people and society, and how does that affect relationships and all that? Well, that's my point of view and my perspective. And I'm really interested in digital health to improve clinical work, the clinicians' everyday life. So it's very much for me related to professional health, and how may e-health actually contribute to making it even easier, maybe even funnier, to increase job satisfaction for the general practice. And I try to do this by being myself from a different field of research to really be interdisciplinary and to collect great teams of experts for many different research methodologies, but also to include clinical experts and patients while doing so. So to do this in an interdisciplinary approach, and to also do it in broad partnerships. And in that sense, you can say we stand in front of a crossroad here. Where should we try to create continuity of care, the personal doctor-patient or nurse-patient relationship? How may technology contribute to increase that or improve that? Or are we going to the other direction here, where we are dealing with a huge societal developments, and that may result in a more episodic care, where user experience and expectations are changing, so that you are much You have another demand to the services nowadays. You would like easier access, more rapid decisions. And how does that affect the reality? And in that sense, it's much, maybe not only looking like a crossroad from above, it's more like an intersection where it's actually a bit uneasy to move forward. And in that sense, you could define e-health as the use of information and communication technology in support of health and health-related fields. That's the WHO interpretation. And that includes, in their opinion, m-health, which is the use of mobile wireless technologies for health. So e-health is and m-health could be coined in that sense. But and a few years ago, WHO actually introduced this wider digital health framing, an umbrella term also integrating e-health and m-health. And that actually then moved not only from information and communication technologies, but also included advanced computing sciences. So how do we maybe introduce artificial intelligence, or the other way around, intelligence augmentation to make use of all these data and all these technologies. So that's my suggestion, at least, that we also discuss e-health in a wider context. And for the past year or so, in many, many countries, I believe we have faced huge, huge developments. I mentioned my conversation with colleagues from Ireland, and they jumped 10 years in a year's time. So the instant movement towards e-prescribings, for example, was driven by the pandemic, but also how electronic vaccination management was automated this way. And we've also seen new forms of consultations. So video consultation came about in a more regular basis. Email consultations also developed to keep clinicians safe, to protect patients, especially vulnerable patients. So many, many things happened the past year, and what can we learn from that? And I have just give you a few examples, one from Finland, symptom checker, and some video consultation data from a few different countries. So in the Finnish case, and Ilkka can also go through this if you need more details, before November last year, the professional had to make the test referral without other contact to the patient. And then in November, this self-referral to test became possible. And we can see in the blue line around November's time that actually fulfilled the demand. And after November, also making the referral to lab was actually automated. So more than half in the city of Helsinki, more than half of consultations were actually self-service, where this symptom checker application then suggested referral for coronavirus testing, and the citizen had the test without other contact with the professional, the blue line, while also other opportunities were still available, that being online, telephone, on-site consultations. That's the other colors below. So we really see this rise in using e-health services when the context is appropriate and when there is a trustworthy system set up. Another case is video consultations. I think it's been widely used in Australia for many, many years. I guess in a Danish context, to discuss that something is remote is maybe a little bit to take it a little too far. But in other countries, such as Australia, I guess it's more suitable and appropriate to discuss actual remote medicine. So we've seen from March and on that a huge percentage of all consultations were carried out with the use of telehealth intervention. And I guess this is quite recognizable for you in other countries as well, that telephone consultation really was the winner, so to say. It's not a new technology. Telephone trial has been around for many, many years, but maybe this situation then resulted in getting back to basics. We saw some rise in video consultations, but not so much compared to how it was before the pandemic. In Denmark, we had an evaluation report published in March, actually, from the pilot projects about introducing video consultations in general practice, and it was really not that positive. Many technical problems A lot of uncertainties about roles and responsibilities resulted in not so positive attitudes toward the use of video consultation. And then a few months later, it shifted to the new normal. And that led to a project we did together across the research units for general practice, where I'm working with digital health, to really collaborate in these 4 units across how to prepare general practice for video consultations, introducing such implementation support materials, because that was the case in Denmark, at least. It just was introduced overnight without any training, without any guidance. So we tried to develop such implementation support tools. But the reality in Denmark, like in Australia, was that it had some initial momentum, but over time it simply decreased its usage, and was also the telephone consultation was rising in Denmark. But what's quite interesting is that we have some data where patients actually rated these consultations, and this is from a period over 3 months, where patients with the shortest average waiting time, that's the blue line, and the longest average consultation time, that's the orange line, actually gave the lowest rating in this MyGP application. So again, there's so much we do not know still, and we need much more research in this field. Why is this so? But it's at least interesting to see these kind of correlations. From Norway, it's basically the same picture here. Many e-consultations happened the past year, especially in the first few months. Most of them were conducted by telephone, and others were through video. And what's interesting in Norway is that they asked the GPs, of which have responded around 2000, how they thought the future of video consultation would look like, what would be the more suitable clinical use. And the majority actually mentioned it would be rather more appropriate for follow-up consultations rather than single-off visits. So I guess that's also what I've heard around. And that's quite interesting because the RCGP just recently published this GP COVID-19 recovery report, also reminding us how the relationship between the patient and the GP is actually the most important feature of general practice. So relation-based care, which is care in which the process and outcomes of care enhanced by a high-quality relationship between doctor and patient, is maybe what we should strive for. And my question would then be, so how could technology enhance that relationship? There are some dilemmas. We know there is problems with gender. In many low and middle income countries, gender is actually a huge problem. Many women do not have access to the same devices as men, then do not have access to internet, for example. We face many problems with literacies, and I term it X-health literacies because we could call it anything from M-health literacy, E-health literacy, digital health literacy, organizational health literacy, you name it. So who is then responsible for actually enhancing competencies to make it second nature to use such devices and to talk about them in a meaningful way? Another dilemma could be the continuum between if an app, for example, should be a standalone solution, or if it should be introduced in a clinical setting together with a therapist. That's like a warm app. So we do not know much about when is an application and an interesting intervention alone, and when would a clinician be needed. And we know a little bit about this, but you know, with so many apps on the market that hasn't been produced or tested in this context, we still don't know that much. There are other kinds of dilemmas. The research base is actually not that strong. It's a young research field, it's just emerged. Evidence is scarce and scattered. We do not have any long-term proof. And there are, as I mentioned, so many healthcare apps on the market. So how do we move forward? Well, we could start by building up nice evidence. And from this GP Info project in the Netherlands, an independent website developed by the Dutch College for General Practitioners, we discovered that 12% less consultations with GP was actually what it resulted in. But that, on the other hand, was converted into more complex and longer consultations for GPs, since those who could use this e-health service maybe clarified some questions in advance, then didn't show up, increasing patient safety. But on the other hand, GPs then, and I guess this is relevant for the GP professional health perspective, were left with more complex consultations. We know, at least from Denmark, some studies about burnout, about job satisfaction, that it's quite interesting to have this in mind when we discuss e-health. Who are we actually serving introducing these tools? So we still need new projects to guide us that way. And as I mentioned to begin with, I would really recommend us to be more interdisciplinary in this sense, to make good use of humanities and social sciences, to get to know on the individual system level, but of course also to link up with general practitioners and health-related researchers to also make it clinically relevant. And I guess also to base it on broad partnerships, so that we get a neutral standpoint. In the Danish context, with this MyGP application, for example, it was developed with the GPs trade union together with some tech developers, so that we knew from the very beginning it was trustworthy and it was transparent. And and a way forward could be in a more theoretical way to rely on a realistic approach moving forward, since this would enable us to guide policymaking with evidence and to make it practice-based. And realistic research is something about what works for whom in what circumstances and why. So to explore the context something derives from and within, and to understand the mechanisms leading to outcomes. And the Medical Research Council just updated their classical framework. And these 6 core elements are so crucial to bear in mind before doing any complex interventions. So do we understand the context well enough? Have we engaged the right stakeholders? Have we identified the key uncertainties and also the economic considerations before intervening? And all that contextual knowledge could guide our projects. And then we're moving to the final part of my presentation about policy. So I used some social media to ask for comments, Facebook, LinkedIn, WhatsApp, you name it, because Ilkka and the group prepared this policy statement 5 years ago already. And it introduced a recommendation for coding of high quality data, to build up such repositories, to share data in an anonymized and encrypted way, and to also have this educational and training perspective in mind to increase health literacy. And if we look 5 years later how this came about, we can see some significant gains in public health population management. We can see a lot of data coding developments, but in terms of fair data management, where we also would like to reuse data and to make it interoperable across researchers and domains, we still have a long way to go. And this goes, from my perspective at least, for many university settings. So it's a real difficult task, this one, to share data, not only also due to GDPR and privacy issues also on the agenda these years, but also that e-health is, and digitalization of societies and public sectors is actually a wider development now. And we've seen this urge for sustainability, where we also use and spend our resources wisely. And to conclude my talk here today, which key requirements would we need to mainstream our e-health? It would require that we have a digitally skilled workforce, that we empower users by increasing their health literacies, but most of all, that any e-health tool or service would be integrated into routine practice. And a part of that is already from the very beginning of the development process, that GPs and similar users as such, those who are going to use these tools and services, that they are also invited into the development process from the very beginning, so that we develop tools that are actually needed in a meaningful clinical way. We should also build them so that we can trust them, and it's transparent, that data sharing is out in the open. It's estimated that up to 92% of all health data, for example, is actually stored in the US. So do we need European infrastructure? Do we need other ways to move forward here to actually be trustworthy to move forward? And the reimbursement and funding reforms is, of course, also a critical part here, because if it's not integrated in the current system, then it'll just be additional work and so many obstacles to make it work in a daily practice. So that's the way forward to improve the whole digital ecosystem, to involve the right people at the right time throughout the whole process. So if we look at this picture from the very beginning about, are we at this crossroad between continuity of care and episodic care, I would just suggest us to ask questions like what works for whom in what circumstances and why, because I believe this could guide us forward. So it's not an either or situation, but for some it might be useful to insist on continuity of care, while for others it could actually be all right to be a bit more episodic, especially in areas, in remote areas where we are also, even in Denmark, challenged by to employ GPs out of the urban areas. So we might need to ask these questions to guide us to take new decisions. And taking home my talk here, just to sum up, so we need to learn from general practice. Much has happened within eHealth the past year. Of course, many dilemmas arose, but also much knowledge and experience has been gathered. So we need to transform those experience and expectations into research repositories where we develop a more hybrid model, I guess, repository model, both using centralized approach, but also decentralizing usage, so it's actually relevant on in a daily level, and that knowledge could guide policy, especially if we do it in a realistic way, being able to guide different target groups, because it's so much more applied. So I guess that's my talk for today. I would love to discuss further with you. I hope you have many questions afterwards. Thank you very much.
Thank you, Ulrik. And thank you for the audience for the interesting questions so far. If you have more questions for Ulrik, please ask them in the Q&A. I would like to introduce our next speaker, and after this presentation, we will start the live discussion. Lieve Peremans is a general practitioner and assistant professor in Antwerp, Belgium. Her research focuses on manpower planning in primary care and care for vulnerable people. And she's an active member of the European General Practice Research Network, where she coordinates a collaborative qualitative study on positive factors for retention of general practitioners in Europe. She prepared a talk on the health and well-being of GPs. Lieve, the floor is yours. Oh, Lieve, you're still muted.
So thank you for this nice introduction, Anouk. The original title of this talk was GP and Professional Health, but I changed it a little bit because a professional GP is a healthy GP, and that's what I want to talk about today. So I invite you also to put some questions in the chat. Please don't hesitate to do that. I'm not going to, first of all, I have nothing to disclose. And I'm not going to talk especially about COVID-19. I think a lot of talks has been done already, but I want to give you a helicopter view on the GP and his health and the GP as a professional. So my talk will consist of 4 parts. First part is the GP as a professional. Second, we will talk about healthy GPs. Who are they? What's going wrong is the next part. And I want to end with how to get and keep healthy GPs in the profession, because that's what we need for future. So first of all, I want to focus on the GP as a professional. Medical professionalism is really a very complex concept with a lot of issues in it. So the art of being a good doctor is on a personal domain, being a good communicator with your patients, but also being a good medical expert. But we also need to be a good collaborator, and we need to be a good manager in our organization. So with other words, we need to be Superman and Superwoman. And one of the models, which is really explaining our roles as a professional, are the CanMeds roles. Everybody knows it, but I want to put some attention on some things in this CanMeds. First of all, there is something strange. In all the pictures of the CanMeds, the medical expert is in the middle. And you can say, yes, but this is our most important role. But if you look at the concept of professionalism, in fact, professionalism encompasses being a good manager, being a good collaborator, being a good medical expert. And another thing is, if we look at the professional role, you see here, it's about a good behavior, it's about your behavior, it's about resilience, and it's about well-being. That's nice, and that's important, especially this focus. But when I start to read and to look at medical programs, and that's one of my first points, look at your medical education programs, but also if you look at research, you see that the content of the role as a professional has changed. It's changed over culture, over languages, over time. And the behavior is the most important one. Being ethical, responsible, having compassion with your patients, being respectful for your patients, coping with complex situations, and sometimes coping with your own emotions. Even in Canada, I found a study where they look at the perceptions of medical residents about all these CanMeds rules. And you see, of course, residents scores the medical expert as the most important role. And you see the professional is in the middle, somewhere in the middle, where there are low scoring rates. But what was striking more, in fact, was that the professional role includes a lot of issues formulated by the researchers and the teachers here, and showing professionalism. And if you look to the GP or the student, well-being is not in it. Clothing is in it, but not well-being anymore. So where is it? It has been gone. It has been gone in a lot of studies. You don't see anything about well-being and professional health. And that's worrying me, because it's one of the main issues to be a good doctor. And it's not anymore in it. So it has changed, and we have to be aware of this. On the other hand, we have professionalism, but we have also healthy GPs. Are we so healthy? How healthy we are? Yes, yesterday evening in the research masterclass, there was a quite interesting talk about from Lilach Maletsky from Israel, and they did a survey, a 2 minutes during survey where there were more than 4,800 respondents. And they asked to the behavior of the doctor and their health. And the respondents were all kinds of physicians, not only GPs. Maybe you have to reflect for yourself now. More than 1 out of 2 doctors have no own GP. More than 1 out of 2 doctors were overweighted. 37% suffers from mental stress. More than 1 out of 5 didn't sleep even 5 hours at night. And 70% of these doctors didn't meet the limits of daily physical activity. The interesting part of this study was that there was an intervention. So they organized a big conference in Israel for all these doctors, but not a conference with medical talks, but a conference with lifestyle events for the doctors, smoking quit sessions, resilience sessions, and so on. And they did it again in 2020. They did it online because of the COVID. It would be nice to see what were the outcomes of it, if doctors were realizing they have to change their behavior. What also changed with COVID was, and it was a talk in the last EGPRN meeting from Richard Main from United Kingdom, and he was talking about, are we sitting too comfortable? And then I can maybe also refer to the former speaker, because we are doing more telemedicine. So what were the results? In fact, as a GP, we are moving lesser than our colleagues in the hospital who are running through the corridors maybe, but we are sitting. And COVID-19 makes that we are even sitting more. And so we don't meet the daily criteria for physical activity. One of the solutions was maybe we need a standing office to do our telemedicine consultations. Another issue is that we, for instance, we are biking and doing our home visits by walking. It could be also a suggestion, but in times of COVID, we did lesser home visits. Although a healthy GP is a key for a healthy patient, and this is not only in this systematic review, but also the WHO has concluded that in reports. So, for instance, if you are living in a community and you show a healthy lifestyle, then you can convince your patients better to do something at their own lifestyle. And satisfied GPs give more attention for prevention. It's so if you are a good, feeling well yourself, you will convince your patients better to participate in screening programs like breast cancer screening, colorectal screening. You have more attention for that. Healthy GPs are adhering better to guidelines, and they prescribe lesser medication and lesser irrelevant examinations. So you are better for the patient's safety when you are a healthy GP, but you are also, if you are a healthy and a satisfied GP, you are better and nicer for your colleagues, and there is a better interprofessional collaboration. But a healthy GP is more than only having a healthy lifestyle. It's also, you need to feel well in your body. And there are 3 important components in this concept of well-being. Autonomy, because it's very important, and we'll see it later on in my talk, that autonomy is very important. Bigger organizations are now managing healthcare, and not only GPs, but all healthcare providers and all specialists are losing their autonomy. They don't involve anymore in how practices are organized. And this is really a very bad way to go. This is not good. we need to have the competences, and that's also important with our residents and trainees. When we don't have the skills to do, and we don't feel to have the skills to perform some things, it gives anxiety, it gives stress. And for instance, I don't feel very comfortable with minor surgery. So I do it together with a colleague. It gives me lesser stress, but I'm more confident in gynecological issues. So we work together in a practice where everybody knows what are your strong competences, and recognize that for yourself. The relatedness is very important. You have to be related in a family, but also in a community. And we come on that later on. And what could go wrong with a healthy GP? Well, we know all the studies of burnout. And Rothenstein, she performed in 2018 a systematic review with 180 studies on burnout. And guess what? I was really astonished. At least 142 definitions on burnout. And then most of the studies used the mass-like burnout instrument, which is a validated an instrument and the golden standard, people tell. But it's a golden standard if you use it in a proper way, and not if you are adapting it all the time. So people adapt this, and then guess what? You get a prevalence of 0 until 85% of burnout. In popular press, they say 1 out of 2 doctors is suffering from burnout. But this is really true. Is this really burnout? If you look at the contributors of burnout, you see there are individual factors, like, for instance, female doctors seems to be higher odds for burnout because of a work-home disbalance, meaning that they take their work at home because to be with their children, but then there is no limitation, there is no border between both, and they are working at home. Personal factors, like, yes, you need a good family who is happy in the environment where you are living. Personal and interpersonal skills to cope with stress, very important one. And then the medical errors. Medical errors, when they exist and you are the victim of a medical error and you are working in an environment where there is no policy for safe reporting, for second victim care, you are keeping all this stress with you, all these negative thoughts about medical errors with you, and you develop stress because you can't share it. And if you have stress, it leads to more medical errors. And then there was some particular thing I discovered, intolerance of ambiguity. Maybe you are familiar with this, but it's quite interesting. If you look, ambiguity is in fact when there is not enough reliable, credible, clear information. And if you have problems to deal with that, it leads to uncertainty. And you see it already with students, but you see it also with doctors who are in practice. And certainly a general physician has to share with this ambiguity, because our patients, they are not always clear in their information. They don't give always reliable information. They say they take their pills, but they don't take, and you are going further on that. So it also, even medical research and articles, they don't give always the same outcomes. So we have to learn to share with these conflicting outcomes, and it leads to uncertainty. What do we need to do? What is good medicine? And this leads to stress, or can lead to stress. It's not necessary, but it depends how vulnerable you are. And then there is, I think, a big mistake, because everybody is talking about burnout, but not for everybody the pathway goes through burnout. It can go immediately to mental health disorders, but the fact that burnout is coming up is also because the organization is not functioning well. If you are working in a dysfunctional organization, you are more likely to suffer from burnout than if you have a sound organization. We all have stress, and we certainly with COVID-19, but in some organizations, everything went well and people are feeling still well. And it depends on the organizational factors. So work factors are very important. E-health might be important, but it may not lead to excessive workload and inefficient work processes. If it's not functioning well, people get stressed. Too many work hours, if you have no support of your colleagues, if you lose your autonomy in the organization, if you are doing meaningless work, and also the physician payment system. If you are working in a system with incentives and which is performance-based, you will have more stress. We see it during COVID-19 in the practices in Belgium also, when people have no consultations anymore, no contacts, they earn no money anymore, and they get in financial problems. So what are the consequences? The consequences are also on the patient level. There is lesser patient safety, but also more medical errors, longer recovery times for the patients, and also for the healthcare organization, because people are becoming on sick leave and they are less reproductive. So there is less continuity of care and less access for patients. And then the most important one is also the physician health, because this leads to using drugs, alcohol, car accidents, and unhealthy situations and depression for doctors. So how to get and keep healthy GPs? Well, we did a large study in Europe, a qualitative study with EGPRN, and we look at the positive factors. And I think yesterday there was someone who asking, what do you think is important to keep GPs in the profession, but also to make it attractive for young doctors? So I will say, stop about all these negative things and start to talk about positive things. And which was also happening in this study was that GPs, even on thinking on stopping with their work, they, in the focus groups, they were so pleased with this conversation that they said, but my job is so nice. Why do I always focus on the negative things? And they didn't leave their profession. So what do we learn from these happy GPs? Be related with your community. Think at the well-being concept, be related. If you are going to work in a community, feel you at home in this community, but not only you, also your family. That might be a problem for, yes, the problem with the rural areas where there are not enough GPs, but maybe we have to think about other concepts than that GPs are not leaving there really, but yeah, we have to think about that. But being in a community where you are not happy, you will not continue to perform there. The intellectual aspect is really very important. Please show that we have a very high intellectual and stimulating work. We are not just treating coughs, we are treating people with multimorbidity. We have really a very exciting profession where we lead to learn to work with uncertainty, with medical decision making. Autonomy in practice goes from giving your personal touch at your private consultation room, showing who you are, and being involved in the organization, being involved in the formulating of the vision and the mission, So go back to the basics. Teaching, doing something else than just clinical work, teaching young colleagues, showing a good role model. Also, supportive factors for work-life balance are very important. And we see in our practices a nice evolution that specialists are a little bit jealous on us because we have a good work-life balance for the moment. We have a much more better organization. In Belgium, there is a good evolution on that point, that people are working together and having a good out-of-hours service, and that's important. So the solution is focus on the quadruple aim instead of the triple aim. Include the physical well-being with individual strategies, but not only resilience and mindfulness. It's only a part of the talk. Small group programs are very important. Go and sit together with your colleagues and talk in a positive way and support them. Look for strategies on errors, on handling errors, and so communication skills training. Communication skills are very important because of patients' own expectations and the organization on the other side. Organizational strategies, reduction on working hours, and so on. So what does this mean for education? Put the professional role in a central position. Please look at the role of the professional in your curriculum. Include well-being tutorship from the beginning, coping with uncertainty in clinical decision-making courses. Role models are important, but let them show also how they handle uncertainty, how they handle medical errors, teach about safe incident reporting and second victim care. Studies about burnout, use a sound instrument, and maybe you have to overthink to use the Copenhagen burnout inventory. Use uniform definitions and concepts so that not everybody is suffering from burnout at the outcome of your study. Longitudinal study instead of cross-sectional studies, and interventional studies with clear outcomes on patient safety and also on individual and organizational levels. So my key messages are: the professional roles should include well-being and resilience and should be in the middle of all. It's the key for everything. A healthy GP is a key for healthy patients. Instead of using burnout lens, we also need other perspectives, and burnout is a continuum and not a yes or no phenomenon. Getting healthy GP starts early in medical education, and keeping healthy GP starts with learning from positive factors. I thank you so much for your attention, and I hope I have inspired you a little bit with this keynote.
Okay, thank you very much for the excellent presentations. Now we have a little bit more than 10 minutes for questions and answers, so I will go straight there. And I noted that there were two themes in the questions, and the first theme was about equity. Mary McCarthy from the UK asked, does e-health disadvantage to old, frail, sick, or those groups who do not have easy access to digital platforms? And then there was other question, what do you think about the concerns that e-health will lead to more disparity, particularly in low and middle income countries? So there were concerns. And there were also a couple of positive comments. Felicity Knight informed that she was interested in work suggesting that marginalized groups can benefit more than majority groups, where e-health interventions are designed specifically with their needs in mind. What are your thoughts on this? And there was also one comment that said that some face-to-face care could be permanently substituted with telephone care for elderly patients. And isolated patients told GPs that they loved telephone consultations during the lockdown. for health reviews, prescription reviews, and advice on new symptoms. So there were concerns, but also some positive opportunities. How do you comment on this, Ulrik?
Yes, thank you very much for these interesting questions. And also I would like to congratulate my colleague for really nice presentation. So from my perspective, I mean, we need to look a bit deeper into this, because for some it might be quite okay to use e-health solutions, but it's a matter of literacy. So if it's difficult to discuss and to track and to monitor, it might be perfectly fine to get a visual output, for example, or to get other means of data involved, such as videos or audio. So it really depends on what we're talking about when we're discussing e-health. So from the Dutch example I mentioned here, this website, the user group was actually elderly. So we do not have any, at this moment, I guess, positive evidence that there's this these structural phenomena going on. We know from Denmark, at least, it appears that those GPs offering video consultations were mainly urban centered, and thereby their population groups were younger patients, for example. So there's this structural explanation around it too. It's not necessarily only the patient perspective, it's also the GP perspective and the practice perspective. And then it's a matter of organizational health literacy. So yeah, digital maturity is ongoing on an individual level, on the the practice level, and also, of course, on the system level, because is it incentive structures, reimbursement structures, also driving how it's offered. So it's not so clear to answer. I'll try to keep it short here, but would love to discuss further.
Okay, thank you. A little bit related questions. Do you feel that there is a difference in attitude towards e-health between younger GPs who grew up in the more digital age compared to older GPs?
Certainly so, but again, it's difficult. If we take the example of fake news, for example, I guess the young ones are actually the critical ones. So they are a bit more reluctant to use it in certain ways. While the middle-aged population is actually the ones maybe a little bit more uncritical users in that way. And then it's a matter, it's a different discussion, because then it's a matter of transparency and privacy. Consent, I want to own my own data, I want to be data sovereign. So I guess it's other values driving usage at different age groups more than anything else.
Okay, I would also comment that it is easier to use e-health when you are an experienced GP. Young GPs need personal encounters to learn how to communicate with patients. This is what has been observed in Finland. Okay, the second theme then in the questions was participatory development of e-health services. Paul van Rooyen from Belgium asked how to develop better e-health and digital health with all relevant stakeholders involved in the consultation process and supporting data management, healthcare workers, patients, ICT designers, who else? What should be the strategic steps to be taken? Andre Rochford commented, do you feel family doctors need to be more involved in planning and design of future ICT for patient medical records, clinical interfaces, data collection through clinical apps development? And there was a third comment involving all stakeholders and also other healthcare professionals in a similar app ecosystem is a true challenge. This kind of implementation may ease interprofessional communication and usability and improve the two pathways. So what do you think about these kinds of stakeholder involvement? And Lieve, I would also then, when Ulrik has answered, you could tell your opinion on, could this relieve also stress and burnout of professionals if they would be able to choose and plan or design their e-health applications?
So if I just start here, so yeah, again, I I certainly so believe that family doctors should be in the very core of any development process, resulting in e-health solutions being applied in the general practice setting. And I guess we've seen some examples from Denmark also, where it can actually lead to continuity of care and coordination of care, because you can then involve a multidisciplinary primary health approach of using e-health. So, for example, have consultations with specialists from other sectors. It could be also in the primary care sector. So I guess in that setting, e-health is a really fundamental way of ensuring continuity. But again, it comes back to that then the developers of this technology should have invited, or if GPs are going to develop such solutions themselves, then at least ensure that you're represented when the decisions are being made. We see, at least in Denmark, a positive attitude also from innovation funding schemes towards investing in primary care digital solutions. So I really believe there's an opportunity now, also probably on the European level, to be a bit more political. This is why WONCA is situated close to power in Europe. So to really use this as a way forward from here to take up this opportunity.
Okay, thank you. Now we have 4 minutes. Let's keep this for Lieve. So what about your ideas on improving professional well-being related to e-health? And then there are also some other questions and very positive comments on your presentation. Would you like to comment on that first?
Yeah, I will do this fast because of the time. But I think I agree that if you can be involved in e-health, it's important as the professional group, but not everybody has to be involved in the developing of e-health. But it might give no more stress, because if the working process is too complicated, if it is not functioning well, it gives more stress. So it needs to be very functional, very easy to use, and not only for nerds in IT. And I agree, GPs or other doctors need to be involved in the development of e-health. Yes.
Okay, thank you. Then Margaret McCarthy commented, do you think that general practice is sustainable when there are less than 1,000 patients per GP and less than 25 patients a day and 8 hours or fewer working time? How important is to limit the number of patients and number of encounters?
I think this is one of the main issues. You have one of the things for well-being is that people have not too many working hours, but then you have the other side of the debate that there is lesser access for patients. So you need to make a good balance. And I think the key is in the efficiency of working. I saw that we did a lot of meaningless work before. Now we have another practice type where there are people who are doing, we have now 4 people who are doing the reception, for instance, to do all these COVID telephones, so that we have a better triage. So I think, and we need, and it's the same as with e-health, you need to be involved in the organization of your practice, in the vision. And the vision of your organization is, will we have a patient stop? I'm not in preference of that, but will we see how many people we can handle in this practice in a decent way, that the patients are feeling well, we are feeling well? That's important. So it's not one single point, it's a whole packet of work-life balance. And yes, in Belgium we have the luxury position that the mean number of patients is only 1,100 for every GP. So we have a luxury position, I agree.
Okay, thank you. Last question to Lieve. What about quality circles as a support for professional communication and intermutual support? Quality circles.
You mean because quality circles has two quality circles or groups of people, but quality circle is also used as a quality improvement process in practice. So I think the person who asked the question is more on quality circles, the group of people who are coming together. I think this is an important issue. It's something we can use, these groups we can use if there is enough trustful relationships in it. We can use that as one of the vehicles to start groups to collaborate with each other and to talk with each other about our well-being and what might help us. So I think even in a practice, it's important. We saw it with COVID-19. We had in our practice, nobody has been burned out of the 15 members who are working because we had given presents. We have several talks with each other. We share in an app our things, our physical activities we did, even in limited possibilities during COVID-19, but it helps. And please, I think it's very important which kind of group it is, a quality circle, a Baling group, a group in your own organization, but work in small groups and support each other. And if you see that a colleague is in a bad flow, please help him or her and support her. That's my main message also with your students.
Okay, thank you very much. Supporting each other, I think, a good main message from this whole theme. Thank you very much for the excellent speakers. Thank you for the audience for all the questions. And I wish you a nice 2 last sessions of this conference. Thank you to everyone.